Welcome in, everybody. I know some of you are coming over from Bree's stream just now, but oh man, I normally do not stream on Mondays, but this was too important to pass up. For anyone who may be new, I'm Dr. Ben. I am a physician, and I have taken care of pregnant people, and I have prescribed Tylenol to pregnant people. So this will be an interesting discussion. As I think all of you know, there was a press conference today by RFK Jr. and the President of the United States talking about the link between Tylenol and autism. And funny enough, they announced this months ago, saying that come September, we will have an answer for what causes autism, because apparently research works like that. It doesn't. So if you're planning ahead and saying that we're going to have an answer by X date, it's probably BS, and I would not trust that. Science takes a long time to do well, and oftentimes there are many hurdles in place that cause you to not publish and delay releasing your findings and all that, and the peer review process, all that stuff. It is super messy, and people forget that when you're doing research, right? You're investigating a very small subset of factors influencing a very small population. So it's usually, especially something that they were saying they're going to peg something down within just a few months, is absolutely ridiculous when you think about the amount of time that it takes to really investigate a problem. And the big studies out there are investigating small pieces of a bigger puzzle, for a very narrow population of people. So this just has a lot written all over it. But before I get too carried away with everything, I am going to show you a clip from today's press conference showing you exactly what happened, why we're here, what are we responding to at the moment. So here you go.
Effective immediately, the FDA will be notifying physicians that the use of let's see how we say
Acetaminophen.
Acetaminophen. Is that okay? Which is basically commonly known as Tylenol.
Tylenol
during
is
pregnancy
a brand
can
name.
be associated with a very increased risk of autism. So taking Tylenol is not good. All right, I'll say it. It's not good. For this reason, they are strongly recommending that women limit Tylenol use during pregnancy unless medically necessary. So
I'm going to stop it right there. That's what we're already doing. So there's something I'm going to repeat ad nauseum throughout this stream tonight. The fact that, so they're saying that this link exists, which we'll get into why that is not really the case. But then they're saying, okay, Tylenol's bad. People should not use it during pregnancy, or people should limit it, which we're already limiting it. We're already advocating for safe use, moderate use. We're not telling people to go out and chug a bottle of Tylenol. That is ridiculous. There is a safe dosage. There's an unsafe dosage. And that is different throughout pregnancy than it would be for most other people. We're very careful with what we recommend for people in pregnancy. So for them to say that you should only use it when medically necessary, that's the reason we have it. We have it for its medical necessity. That is why we prescribe it, or you get it over the counter, or we advise you to use this as your first line pain management in pregnancy. And we'll get into all that, but that's kind of a pointless statement. It shows that he does not understand what medicine already does, what the goal already is, and how we already regulate these things and their use in pregnancy.
Ideally, a woman won't take Tylenol?
Ideally, they won't need to, but sometimes they have to, and sometimes they do not have a choice.
And on the vaccines, it would be good instead of one visit where they.
So, okay, so this is where it gets funny. So he goes into the whole vaccine issue. The whole premise for their argument here is from a systematic review of multiple studies related to Tylenol use in pregnancy and uh, risk of autism spectrum disorders or ADHD or other neurodevelopmental disorders. And then he just launches straight into blaming vaccines. They don't have any citations for that. The funny thing is with all this, they're blaming Tylenol when if there was a good connection between vaccines and autism and they could prove a causal relationship, why not do that? You already have so many more people on board for that. But it just seems like if you are already you're not finding the link you want with vaccines and autism. So instead, you're going to jump over to Tylenol, cherry pick some studies, and then add the vaccine issue right into this. And I'm not going to continue with this video because if you want to hear my full thoughts on spacing out vaccines and all of that, I did a stream on the measles just this past Saturday. So go watch that one if you want to hear more of my thoughts about measles and my thoughts on the vaccine schedule. But we're here today specifically for this whole Tylenol issue. So that was kind of the important part. And I'm already seeing so many people commenting on how he can't even pronounce the medication and that he has no business talking about this. Like, why does he believe he is the right person to give recommendations, not only for like what people should take over the counter, but he's making recommendations for people in pregnancy, which if you have physicians who are not qualified to take care of pregnant people, they are very, very anxious. I remember like as an intern being in the ICU with a bunch of internal medicine residents who had never taken care of an OB patient before and were super nervous when we had one actually show up in the ICU who is postpartum. Like, this is a very serious thing. And one of the reasons is because complications of pregnancy are very, very deadly, or they can be very, very deadly, and not only affect the pregnant person, but can also affect the infant. So this is a big deal to be making recommendations to people who are pregnant. So I know it's kind of a bit of an intro. We'll slow down a bit through the rest of this. I have so many tabs open right now as we get into this. And if anybody has any specific questions, super chats are available. They will be priority. I'll try to get to any other questions in the chat kind of as they come in, although there's a lot to cover tonight. And I am seeing in the comments already, and something that was already on Facebook, the fact that Tylenol was invented long after the diagnosis of autism was actually like given a set definition. So the first kind of documented cases of autism under the current definition were kind of in the early 1910s, like 1911, I think I saw. And Tylenol was invented in the 1950s. So a huge gap in time frame between these. So if Tylenol is the missing link to what is causing autism rates to go up, it doesn't really make sense for the timeline. But I'm going to pull up a few. So first of all, I'm going to dive into a statement from ACOG. So if you're not familiar with ACOG, this is the American College of Obstetrics and Gynecology, and they are essentially the expert board for anything pregnancy. And I have some other statements too from released some studies from the specific subspecialty of maternal fetal medicine, which deals with complex pregnancies. But if you have questions, and this goes for this issue, this goes for issues related to reproductive rights, this goes to if you have questions about birth control, if you have questions, especially questions about myths that are going around, things that you're not sure about, ACOG does a really, really good job addressing frequently asked questions. And I can actually, I'm going to include the link to this article in the side chat. If you want to follow along, you can also explore their website for a bunch of other educational stuff as well. I know some content creators out there also, delve into the space if you're interested in talking more about reproductive issues. ACOG is the go-to for U.S. standards of care. So I'm not pulling any of this information like from out of my ass. Like this is the consensus. These are the experts that I would recommend going to and getting your data from. So this is a statement from today. They also have a similar statement from back in 2021. This argument is not new. This myth is not something that just sprung up. This has been perpetuated since 2015 or 2017. It's been a long time. It's been about a decade since, at least as far back as I've gone to look at this. But ACOG says suggestions that acetaminophen use in pregnancy causes autism are not only highly concerning to clinicians, but also irresponsible when considering the harmful and confusing message they send to pregnant patients, including those who may need to rely on this beneficial medicine during pregnancy. Today's announcement by HHS is not backed by the full body of scientific evidence and dangerously simplifies the many and complex causes of neurologic challenges in children. It is highly unsettling that our federal health agencies are willing to make an announcement that will affect the health and well-being of millions of people without the backing of reliable data. In more than 2 decades of research on the use of acetaminophen in pregnancy, not a single reputable study has successfully concluded that the use of acetaminophen in any trimester of pregnancy causes neurodevelopmental disorders in children. In fact, the 2 highest quality studies on the subject, one of which was published in JAMA, which I do have the JAMA study pulled up for us to look at, found no significant associations between use of acetaminophen during pregnancy and children's risk of autism, ADHD, or intellectual disability. These studies that are frequently pointed to as evidence of a causal relationship, including the latest systematic review released in August, include the same methodological limitations. For example, a lack of a control for confounding factors or use of unreliable self-reported data that are prevalent in the majority of studies on this topic. Acetaminophen is one of the few options available to pregnant patients to treat pain and fever, which can be harmful to pregnant people when left untreated. Maternal fever, headaches as an early sign of preeclampsia, and pain are all managed with the therapeutic use of acetaminophen, making it essential to the people who need it. The conditions people use acetaminophen to treat during pregnancy are far more dangerous than any theoretical risks and can create severe morbidity and mortality for the pregnant person and the fetus. When considering the use of medication in pregnancy, it's important to consider all potential risks along with any benefits. The data from numerous studies show that acetaminophen plays an important and safe role in the well-being of pregnant women. So there you go. There's a statement from ACOG. This is true. When we are thinking about when to use medications, how much medication to use, there's a lot that goes into that decision. And like I mentioned, with how critical this information is with managing a pregnancy, you have to weigh out, there's risks to any medication that you're going to give. We know that with high doses of Tylenol, there is risk of liver damage because of the mechanism of how Tylenol is metabolized. It is metabolized through the liver. And so that's why people who have liver disease could have liver injury or liver failure from excessive use of Tylenol or using it beyond a normal dose, or even sometimes a normal dose can be harmful for people with severe liver injury. So we have to be cognizant of that piece. We're very cognizant of people who use Tylenol with significant amounts of alcohol, and there's a pretty complex relationship between those because they compete for receptors and compete for enzymes that metabolize them. So it can be harmful to consume a high dose of Tylenol while consuming a high dose of alcohol. That is not recommended. That's why the bottles say do not consume with alcohol. So we are careful about how we use these things. But when you think about conditions like maternal fever, thinking about things that can harm the pregnant person and harm the infant, especially when somebody is planning on keeping this infant to term, uh, maternal fever can be very problematic. Inflammatory responses can cause additional issues thinking about vascularity. You have blood flow that's going from the placenta, from the fetus to the placenta to the parent and going back and forth. You need that to stay well open for that circulation to continue. Inflammatory issues can cause vasoconstriction, in some cases, kind of blocking that off. You have probably the best example here of an issue is preeclampsia, where if you have somebody coming in their pregnancy, we often ask them about their headaches, if they're having headaches, and if they go away with water and adequate hydration, if they're going away with rest, or if they're going away with Tylenol, because headaches can indicate end organ damage as a sign of preeclampsia, which is a medical emergency and could be the reason why somebody may not be able to carry a pregnancy fully to term, especially when you're getting to a place where you're worried of neurological damage in the pregnant parent. You may have to deliver around 37 weeks of gestation, which is technically term, but still still earlier than most people would want to deliver a baby, to even 34 weeks, or in some very emergent cases, as early as possible. And headaches kind of being one of these symptoms that we watch out for. We rely on Tylenol not only for relief for these headaches for people, but also to give people that warning of, hey, you should try this out. If it doesn't help, it's probably because you're having a more serious complication and we need to deliver right away, or we need to at least get you hospitalized until you do deliver. So this is a very, very big decision. And so trivializing this to, well, we don't like this association that there may be between Tylenol and autism, even though it cannot be demonstrated. The fact that they think that that is enough of a reason to completely flip the medical consensus and to completely flip how we manage patients is insanity to me. People, especially if you have never managed a pregnancy, if you've never been pregnant, if you've never managed a pregnancy and do not know where this could lead, you should not be weighing in on this decision. This is very, very scary. And I worry for people who are going to start taking this advice over the advice of their OBGYNs. Because unfortunately, people are very impressionable. So yeah, exactly, Val. Like people. Oh yeah, and thank you. Love you too. um, but yeah, people are going to die from this. This is awful. And Emmer makes a fabulous point. There's nothing wrong with autistic people. Neurodivergence, as we are learning, is a variation of normal. It is a variation of how the human brain can work. And yeah, it can cause some social distress for people, like in the same way that being trans or being gay can cause some social distress. But the distress is not usually related to the divergence, the distress is related to being in a society that views your divergence as bad and views it as something that you have to get rid of or you have to mask. That is really the problem. And so to say that neurodivergent people are so problematic that we would rather risk people who are pregnant, risk their safety, that is completely irresponsible. And, I do not support that stance. So the one thing that I agreed with so far within that press conference is I agree with not using medications unless they are medically necessary. That's just, a general premise of practicing medicine. And the other thing is that, that you don't take higher doses than you should. But with that, I think you should be able to make that decision with your healthcare provider. And like with all that, you have every right. You have every right to say, no, I do not want to take the medical advice that is given to me. Sometimes you might have to sign a little waiver that says, hey, this is what was advised to me. I understand the risks and benefits. I'm choosing not to do this. That is entirely your right to do. The problem is when somebody else who is not qualified thinks that they're telling you how to make that decision without any credentialing, without any licensure, without any accountability for what they're doing. And then you just take that statement and run with it because you don't know any better. That is the problem here. And AJ, we will get into this. We will get into that later on. There's so much juicy stuff here. But that is kind of the big statement. So I think next we're going to go to the study that ACOG cited. Actually, you know what? I'm going to go to their FAQ screen first because they have a really nice FAQ page that we can go to because they've been answering these questions for a while. So again, I'm going to link this in the side chat as well for if you want to share this out with any of your friends and family who might be buying into this. There you go. So these are their FAQs on this issue. So we already read ACOG's position. ACOG supports the use of acetaminophen in pregnancy when taken as needed, in moderation, and after consultation with a doctor. Absolutely. I love that stance. What should pregnant women be aware of when deciding whether to take acetaminophen given the conflicting information from HHS and ACOG or their OBGYN? So they say essentially the same thing. Acetaminophen is a well-studied and proven to be safe for use in pregnancy and is one of the only medicines available to pregnant women for pain relief and treatment of headaches and fevers. And this is true because you cannot safely take ibuprofen in pregnancy. You cannot take naproxen. You cannot take anything of that class of medication because it can cause complications within the fetus. So there are certain compounds, certain inflammatory compounds in your body that prevent a hole in your heart from closing. And you need that during certain stages of development in order for your heart to, circulate the way that it needs to in utero. But that ends up closing later on when you're born. And so you don't have that hole in your heart anymore. But closing that too soon is very, very problematic. Closing it too late can be problematic. So that's something that NSAIDs, specifically that class of medication, can have impact on. And so for developmental reasons, it is not recommended to use ibuprofen in pregnancy. What you need to use usually is Tylenol. So a lot of these reasons kind of factor into what medications are we going to offer to somebody. Tylenol is the most safe pain medication and anti-inflammatory that we have for use in pregnancy. So Science does not support claims that acetaminophen used during pregnancy leads to autism. In fact, robust recent data have reinforced that acetaminophen use during pregnancy is not associated. And then they go on to say, like we said, failing to treat medical conditions that warrant use of acetaminophen, such as maternal fever, persistent headaches, and pain, can be dangerous. When left untreated, these conditions can, in some cases, create severe risk of harm or death for the pregnant person and the fetus. They go on to answer, how long have researchers been studying this use? And kind of skimming this over, the FDA and the Society for MFM did their own reviews in 2015 and 2017, respectively, and came to the same conclusion. I have the study from the MFM pulled up as well. I think I closed the link for the FDA study, but we'll look at that too. Have any research studies successfully proven or disproven a causal link between acetaminophen use in pregnancy and neurodevelopmental disorders such as autism? And they're going into, the same thing. And there's some more studies here. Gustafsson et al. 2021 and Alkvist et al. 2024, which I think that's the one I have pulled up, is the Alkvist et al. 2024 study. I have that one pulled up for us to look at. Latest evidence. So they're going to kind of go into the study. We're going to go into all these more in depth. But there was a publication in 2021 in Nature that raised questions initially about Tylenol use in pregnancy. And since then, it's been highly studied. And we will look at this one as well, because this one actually, I believe, is either a UK study or somewhere outside the US, because they mention paracetamol, which is the UK funny word for it. And I apologize that this font is kind of small. I'm going to zoom in a little bit. But they actually go into some interesting things beyond concerns for autism. They also go into intersex conditions being linked to Tylenol use, which I'm trying not to get ahead of myself here. But there's that thing. What is the latest evidence or research available on Tylenol in pregnancy? This is what we were looking at. The JAMA study, which we will get into, controlled for confounders such as genetics and environmental factors, found no significant associations between Tylenol use in pregnancy and children's risk of autism, ADHD, or intellectual disability. The findings suggested that previously reported associations may be largely attributable to a genetic factor within a family that was not accounted for, rather than a causal relationship. So what we're talking about here, if people are unfamiliar with this, confounding variables are anything that could skew the study in one way or another. So when we're talking about this, especially, in order to prove a causal relationship, for one, you have to narrow down, is it the Tylenol that's the problem, or is there something else that could also be the problem? Like if genetics is a factor, this is why they do sibling studies. So in the JAMA study, they address the sibling issue. If they study Tylenol use in one sibling versus another one, and you don't find the same conclusion, that tells us, maybe it wasn't the Tylenol. Maybe it was something genetic, because these siblings both were autistic and only one of them had significant use of Tylenol during the pregnancy. Another confounding variable could be, if they're trying to suggest that there are other environmental factors as well, such as the location that they live in, like air pollution. Like, let's say if you had 2 cases of autism, or you have to have more than 2 cases, but just bear with me for the analogy. Like if you had 2 cases and one family lived in Delhi, which is one of the most polluted cities on the planet, compared to, the least polluted city on the planet, that could say, well, maybe it was the environmental factors of pollution. Maybe it wasn't the Tylenol. There are so many things that can lead into just additional questions. If they're also trying to bring vaccines into this equation. So if you have all of these children who are autistic and had Tylenol use in the pregnancy and also were fully vaccinated, then you can't separate those variables out either. How do you determine which one of these is the actual cause, if any of them at all? So that's what we mean by we have to control for confounding variables throughout all this. And the studies that are being cited by RFK Jr. are not meeting the criteria to be adequate studies for these reasons. And we'll show exactly how much bias were in these. But to get a little bit like from a broader lens, before we dive deep into this, ACOG addresses the limitations of the specific 2025 systematic review, which was just published in August, that found an association between Tylenol exposure during pregnancy and increased incidence of neurodevelopmental disorders, including autism and ADHD. And before we move on to, I also want to clarify this word incidence. And I do have a video that I did a long time ago on this channel, and maybe one of the mods can dig it up. But I did one about the difference between incidence and prevalence, and this is important. So when if we have a chronic illness or a chronic condition, we have a certain number of people that have that condition within the general population, right? And so some people, as they're born, will have that condition. Some people, as they go on throughout their life, will develop that condition, depending on what condition we're talking about. And then at some point, those people will die. And so they no longer have the condition because they're dead. They're not no longer counted in the population. So the amount of people with that condition is kind of constantly fluctuating. So these terms of incidence is the new cases or the new diagnoses within a certain time frame. The dog just got very loud in the hallway, and I apologize. So the incidents are the new cases within a population. So that's kind of the increase to the general population with that condition within that set frame of time. So usually you're looking at incidents for, let's say, 2025. How many new cases of autism were diagnosed within this year? That is our incidence. Prevalence, was it that the mods? Oh, I have a video from a while back about incidence and prevalence. It was a long form video. If somebody happens to have the link and can put it in the side chat, I'd appreciate it, because I have a picture, like a drawing analogy that'll kind of help with this. Prevalence is the rate of that condition within the entire population. So that includes everybody, both new cases and old cases that have that condition. And something that is often used as rhetoric to tell people, well, look at all these chronic diseases now. This is new. We didn't have all these before. They're thinking about, the prevalence is going to increase over time, especially in our society where we are prioritizing keeping people alive with chronic diseases longer. We're trying to keep more people who have that from dying and leaving the population, right? So the longer people stay alive with a certain condition, you're still going to have new cases coming in. So that number is going to go up. So what we're talking about here specifically is the incidence. We're talking about new diagnoses, new cases of these conditions, and not necessarily referring to the prevalence. And so that's why that word is so important. And yeah, let me click on that link to see if it is. Yes, it is. It is that video. Yep. Um, so if you're curious more in more detail about what the difference is and why it's important, you can go watch that video later. Uh, but the study that RFK Jr. is trying to cite is this systematic review from Prada et al. I do love that somebody has the last name Prada and published this. It has a lot of limitations. One of them we kind of briefly touched on. One of the limitations is that they rely heavily on self-reported Tylenol use with considerable potential for recall bias or biased reporting of events or experiences due to inaccurate or incomplete recounting. So it's basically a limitation of people's memory of if they use Tylenol during their pregnancy or not, their ability to report it accurately and or report it honestly. So there's significant bias with that. Whenever you have a self-reported study or especially if somebody's recounting this from a long time ago, they might not remember how much Tylenol they took during the pregnancy. They're going through so much at that point. Like they have other things to worry about other than accurately documenting how much Tylenol they use during that time frame. Um, a lot of the studies also included no information on the dosage and duration of acetaminophen exposure, and that's important because the dose makes the poison. Let's say somebody took Tylenol once; they took a low dose of Tylenol one time during the pregnancy. If this risk was true, do you think that the person who took one dose is going to have the same risk of somebody who took a whole bottle? No, that's ridiculous. There's a lot of importance on tracking dosages and for how many days they took it or how many months they took it. That is all very, very important to document and to keep consistent. Uh, they're also mentioning that they feature different kinds of assessment. So when people are diagnosed with autism or with ADHD or any other number of neurodivergent conditions, they're oftentimes using developmental milestones to help kind of assess, do they meet diagnostic criteria, or is it this or is it not? They have to have criteria that are standardized to put somebody into that box and to give them that label for the rest of their life. That is a big deal. So how did they diagnose these people? How did they did they standardize the assessments that they use? And it seems that between these different studies, there was not a standardized way to say, yes, you meet this criteria for this condition. So they could have used a standardized method, and that would have eliminated some bias. And then, like we mentioned, controls for confounding factors. Uh, and then something else that ACOG mentions right here that is super, super important. When it comes to any scientific paper, it is important to ask what it adds to our current scientific knowledge and understanding. In the case of Prada 2025, the study's findings don't change the current standard of care for the use of acetaminophen in prenatal, postpartum, or fertility care. So regardless, whether or not there is a link between Tylenol and autism, it does not change the standard of care. It does not change whether or not OBs are going to recommend this for their patient population. The condition of autism is not significant enough to say, hey, you can suffer from your preeclampsia, you can suffer from your headaches. That is not a fair trade-off. It is not going to change our standard of care. So this study seems just very poorly done. Like the reason for doing the study, was this done for political reasons? Was this done to accurately assess, the situation with neurodevelopmental conditions and Tylenol exposure? I don't know. I don't know the intent of the authors, but this is important. Yeah, and I appreciate all of the kind words in the side chat. I really appreciate you all being here kind of later at night for a stream for me. and feel free out there to clip out pieces of this as you need, share out the video. I think I'm going to maybe clip out some segments as well to make it easier for people to access. But feel free to use any of this. Feel free to use any of the citations. I'm going to put these in the description. So if you need to pull out one of these studies, feel free to. I mean, these are actually very easily available. Like, I was able to get these full studies without going through a paywall. So that's pretty fantastic. So let's get into this a little bit. First, I think we're gonna take a little stretch break. Yeah, and Robin makes another good point. Let us not forget that the same bunch of authors who recommended we inject bleach and take horsepower for COVID. There's a lot of interesting bias within the people promoting this particular paper. But first, before we get into like the fun, I can't even say fun paper, the interesting paper, we're gonna get into the JAMA study. Here we go. Because if you are going to cite anything about this topic, this is probably the one that you want to share out, other than the ACOG stuff that I already mentioned. But this is the one that they cite, that ACOG cites in their statement. So for the key points, they say, does acetaminophen during pregnancy, I'm going to make this bigger. Does acetaminophen use during pregnancy increase children's risk of neurodevelopmental disorders? Findings in this population-based study, models without sibling controls identified marginally increased risk of autism and attention deficit hyperactivity disorder associated with acetaminophen use during pregnancy. However, analyses of matched full sibling pairs found no evidence of an increased risk of autism, with a hazard ratio of 0.98, and ADHD a hazard ratio of 0.98, or intellectual disability hazard ratio of 1.01 associated with acetaminophen use. Meaning, acetaminophen use during pregnancy was not associated with children's risk of autism, ADHD, or intellectual disability in sibling control analyses. This suggests that associations observed in other models may have been attributable to confounding. So like I mentioned, this study controls for the sibling issue. So you have siblings. Here, we're going to go through their design. I want to see if they go into this a little bit easier way. Here, they actually do address some of the limitations of other studies too. Yeah, previous studies have also been limited by small sample sizes, leading to inconsistent and imprecise estimates. So that's pointing out another limitation in a lot of those studies. So how did they come to these conclusions? So they included all singleton live-born children in Sweden from July 1st, 1995 to December 31st, 2019, with a linkable personal identifier, with follow-up until December 31st, 2021. So they followed all of these children from 1995 in July to December 2019, followed them all the way through 2021. The individual who gave birth is termed the birthing parent, to use gender-inclusive terminology. The children were excluded if they had missing information on the birthing parent's birth country, age, region of residence, or household education or income, resulting in a final analytical sample of 2,480,797 children. 99.64 of them were retained in the study. So that means the people that were included in the study and then were also able to be tracked in follow-up. And they, of course, got consent from everybody who did this. So there's a lot of people who were included in this study. So this chart here kind of goes into how they got their sample size, how they excluded people from their sample size. So on this criteria, people who had missing information or people who just did not, whose information did not help out with the study. So for example, if children were not exposed to Tylenol during the pregnancy, they were not included in the study. So they were, they were still included. They were included, but the people without the information were excluded for sure. So they have their inclusion and exclusion criteria here. So they had a significantly high amount of people that were born in Sweden over that time frame. They had over 2 million, almost 2.5 million that were still included and were not excluded, as seen previously. You had 185,000, over 185,000 that were exposed to Tylenol, over 2 million that were not. And then you had, of those that were exposed, you had over 16,000 that were diagnosed with a neurodevelopmental condition. And then of those who were not exposed to Tylenol, had over 172,000 of them who were still diagnosed with neurodevelopmental conditions. So you have people who are being diagnosed who were exposed, and also some who were not exposed. And you also had 1,773,747 full siblings from that over 780,000 families included in the sibling analysis. So that is a massive, massive sample size. They have a lot that they're working with here. Hi, Casey. What's up? I'm glad you made it. But yeah, so incredible sample size in this. And you're still getting autism in both of the populations. So a lot of this going into kind of more of the stats of how they used the data that they had. And again, if you want to learn more about confidence intervals, I have separate content specifically going into statistics and how we kind of calculate this stuff. So please go watch that. I maybe need to redo some of those videos, or at least re-release them so that we're kind of up to date on this stuff. But without going too heavily into the stats, here's a table with all their data. You can flip through this on your own too, as I did I already share this link in the side chat? I don't know if I did. Y'all can follow along with this if you'd like to. But there's a table. I'm just going to skip ahead to the discussion of the data because this would take us way too long. Actually, okay, here's actually something I do want to get onto. Oh, here we go. There's an absolute risk difference here that we will touch on. Absolute risk difference is the difference in absolute risk at 10 years of age between exposed and unexposed children, expressed as a percentage. For example, the 0.09 absolute difference for acetaminophen and autism can be interpreted as follows. The risk of child autism at 10 years of age is 0.09% higher with acetaminophen use compared with no acetaminophen use. The population-based model was adjusted for birth cohort, child sex, all other analgesics, so all other pain control methods, birthing parents' diagnoses of migraine, chronic pain, infections, fevers, rheumatoid arthritis, and headaches, calendar period of delivery, parity, so parity is how many pregnancies they've had previously, age at delivery, country of birth, residential or region, cohabitation at delivery, early pregnancy body mass index, smoking status, diagnosis of autism, ADHD, and intellectual disability, history of psychiatric conditions, and prescription use of psycholeptics, antidepressants, and anti-seizure medication, healthcare visits in the year before pregnancy, and an inadequate number of antenatal visits, and the highest household education and disposable income. There is so much here. Like, think about that whole list of things that I just read. Those are all variables that would have to be controlled in order to get to a conclusion that, you know, that there is a link between these, just these two things. And so this is kind of with their attempt to control, for all of these things. You have a 0.09 absolute difference between the exposure. So in contrast, models with sibling control, acetaminophen was not associated with children's risk for autism, ADHD, or intellectual disability, and they have a confidence interval of 95%, 95%, and then yeah, they're using that for all three of them. Again, not getting too heavily into the stats. Carryover bias did not bias the autism and intellectual disability analyses among sibling controls, although possibility of carryover effects for ADHD could not be ruled out. So some of the confounding variables may have existed in the ADHD side of things, but that's not really what we're focusing on today. The other thing I wanted to touch on with this is the dose response pattern. So they did look at different doses of Tylenol. So characteristics of the study subsample with prescription dispensation information for acetaminophen displayed in the table. Persons with higher acetaminophen use tended to have more diagnoses of psychiatric conditions, neurodevelopmental disorders, indications for acetaminophen, and co-prescriptions of related therapeutics, among other differences. So something that needs to be accounted for is, sure, let's give them the benefit of the doubt for a second. Let's say if we assume that there was an association or there was a link between Tylenol and autism. Let's think about what else that means. Why were they taking the Tylenol? What other conditions did they have that could have predisposed them to have a child who is neurodivergent? Like, let's say, could we then investigate risk for people who had migraines during pregnancy? Is there a genetic relation to people who are predisposed to migraines and people who are predisposed to autism? Maybe, I don't know. I don't have the data on that. Same thing with, we know that a lot of psychiatric conditions are heritable. We know that bipolar is heritable. Severe depression can be heritable. So things that you may have predisposition for certain medical conditions, maybe does that put you at risk for having neurodivergence in your family? Allergies, allergies to certain medications. There's so many different factors that go into this that's beyond, is it the Tylenol or isn't it? And I think we could spend days just sitting here sifting through each one of these factors. But the big important thing here with this particular study is controlling for siblings, controlling for that genetic component, controlling for dosages. They have a whole table here categorizing things out by no use, low dose, medium dose, and high dose, and specifically defining what that means. So they're defining low dose as less than 166 milligrams per day. I'm assuming that's per day. Medium dose 166 to 429, and the high dose greater than 430 milligrams per day. Or I'm guessing that might be per dose. I have to actually look at this. Hold on. It's either per day or per dose. I cannot tell from this specific chart. They might have said it in here. Anyway, okay. So the discussion, kind of what we were already hinting at, but I might just read. I'm not going to read this whole thing. Let's find the key points. This first bit is probably good enough. Sibling control analyses found no evidence that acetaminophen used during pregnancy was associated with children's risk of autism, ADHD, or intellectual disability. This suggests that the small increase in children's risk of neurodevelopmental disorders associated with acetaminophen use observed in statistical models without sibling control may have been due to unmeasured confounding. There we have it. In addition, sibling control analyses did not identify a dose-response association between acetaminophen and neurodevelopmental disorders. So with that, with the table kind of above, if we went more in depth on that, what we would expect to see with a dose response is that a small dose would give you less of a risk and that a higher dose would probably give you a higher risk. They did not see any difference between those dosage groups and the incidence of these neurodivergent conditions. So what does that say? It's probably not related to the Tylenol. There's probably something else involved in this. Results of this study indicate that the association between acetaminophen use during pregnancy and neurodevelopmental disorders is a non-causal association. Birthing parents with higher acetaminophen use differed in many aspects from those with low use or no use. Results suggested that there was not one single smoking gun confounder, but rather that multiple birthing parents' health and socio-demographic characteristics each explained at least part of the apparent association. So they're also getting into that, hey, where the person lives, socioeconomic status could also play a factor into this. So we don't really know. The null results of the sibling control analyses indicate that shared familial confounders were involved, but do not identify the specific confounding factors. So again, the likelihood that genetics at least played a small part in this is very likely based on the sibling study. So that's what there's a lot in that one study on its own, but of course that's not the only study that we have that is in support of the, or that is useful in supporting the ACOG consensus. So I'm not gonna go in a lot of depth on this next one, but I did just want to share, the other couple studies that ACOG cited, just so we at least address it. Okay, so this one, and I will put this link in the side chat as well if you'd like to see this one. This is a publication from a different, the Journal of Obstetrics and Gynecology, specifically from the Society for Maternal Fetal Medicine, which, like I mentioned previously, is like the special subspecialty for super complicated pregnancies. So if you have a pregnancy that needs like a whole bunch of monitoring beyond what is usual, MFM might be involved in that. So they're kind of the superheroes you call upon when you don't know where else to go. You get MFM involved. But they go over, essentially they go over the limitations of the 2021 publication. So y'all can read that. We're not going to really go into this one in depth because it says kind of the same things that we've already mentioned, but they give some other references here that helped them formulate this opinion. So a whole list there if you want to go sift through those sources. I'm also going to just briefly show you the FDA paper, or the safety announcement, if you will. So this is from 2015. So this is kind of way back when all this kind of started off being a thing. FDA has reviewed possible risks of pain medicine use during pregnancy. And they kind of go into a lot of the things that I've already said. But I do want to highlight, okay, so this is some of the stuff that I briefly mentioned before. the US FDA is aware of and understands the concerns arising from recent reports questioning the safety of prescription and over-the-counter pain meds when used in pregnancy. As a result, we evaluated research studies published in the medical literature and determined that they are too limited to make any recommendations based on these studies at this time. Because of this uncertainty, the use of pain medicines during pregnancy should be carefully considered. We urge pregnant women to always discuss all medicines with their healthcare professionals before using them. Severe and persistent pain that is not effectively treated during pregnancy can result in depression, anxiety, and high blood pressure in the mother. Medicines including NSAIDs, opioids, and Tylenol can help treat severe and persistent pain. However, it is important to carefully weigh the benefits and risks of using prescription and OTC meds during pregnancy. And so they go into prescription NSAIDs and the risk of miscarriage in the first half of pregnancy. And yeah, I briefly mentioned that. I didn't go into the risk of miscarriage, but yeah, there is risk of miscarriage within the first trimester. Examples that include ibuprofen, naproxen, diclofenac, and celecoxib. All of those should not be used during that time frame. Opioids, which are only available by prescription, and the risk of birth defects in the brain, spine, or spinal cord. Babies born to women who took these products during the first trimester of pregnancy. So opioids are only used during very specific time frames. Kind of usually, if we are going to use it, it's going to be in the third trimester, kind of in like when someone is actively in labor. I know I've used morphine for people who are actively laboring, but that is, very carefully considered. And that was in a residency setting where I was supervised in giving that. So, so that's pretty much all we really need to get into with that particular one. So lots of stuff. We're not done yet. We're not done yet, friends, because we still have yet to get to the study, the systematic review that RFK Jr. is citing. So now that we have our armor, it's not the armor of God today, it's the armor of peer-reviewed, evidence-based data. We are going to take that armor and plunge into the depths of not this paper. That was the paper we just looked at. This other paper. Here we go. I think that's actually, like, one of these is the actual paper, and then I have a couple tables pulled up separately. I do not want to win $100. Why are you trying to scam me on this academic website? Okay, so this is the POTUS study. I'm going to link this in the side chat as well in case you want to follow along. So so I'll just read through their abstract a little bit for you all, and then we'll get into kind of where it gets problematic. And they kind of openly admit that it's problematic. And then people just kind of ran with that. But acetaminophen is the most commonly used over-the-counter pain and fever medication taken during pregnancy, with greater than 50% of pregnant women using acetaminophen worldwide. Numerous well-designed studies have indicated that pregnant mothers exposed to acetaminophen have children diagnosed with neurodevelopmental disorders, including autism spectrum disorder, ADHD, at higher rates than children of pregnant mothers who are not exposed to acetaminophen. So this wasn't a separate study where they took people and like, this isn't a clinical study, this isn't a lab study, this is a systematic review. So what they did is they went into databases and they searched for particular terms to pull up the results, and then they took the results that they had and then they read through them and then made these tables to compare and kind of see what things in common they had and all that stuff. See if they could get kind of tease out some better answers from all of that other data. So this is kind of what we call it's a PICO study, and they have a place in here where they mention PICO. So here you go. It's a PICO framework. So what this means is they think of a population that they want to affect. So their population in this case was the offspring of pregnant women assessed for neurodevelopmental outcomes. So that's specifically who they're looking at. The exposure, so E is exposure, which is prenatal acetaminophen exposure, measured via maternal self-report, biomarkers, or medical records, so not consistent among that. C is the comparator, so the population that they are comparing the experimental group to, which is the offspring of pregnant women not exposed to acetaminophen or exposed to alternative analgesics. And then the outcome, or O in PICO, the outcome is neurodevelopmental disorders, including ADHD, ASD, or related symptoms diagnosed or assessed in childhood. And something that, this is a pretty good framework to go off of. This is something that is done often in academic settings. I remember thinking through a PICO project in my internship. It is a good way to think of how are we going to study these things. How can we find the data that's out there? And it's essentially a way to answer a clinical question that you have. It's a way to say, I have this patient. I need to think of the right way to handle this. What does the data say? And then compiling all of that data and then saying, okay, based on all of this, here's what we think the right course of action is. And there's already interesting things with this. The fact that their outcome is they're studying whether or not people get these neurodivergent conditions, but we'll see that it's the end point, or the outcomes are not super well standardized among the studies that they're pulling in. So within the study selection, here's their kind of chart for how they went about this. So essentially, they went through PubMed. So they did a PubMed search in February 2025 to identify original papers on the relationship between these conditions and prenatal exposure to Tylenol, including observational studies and meta-analyses. So they use PubMed because it's pretty comprehensive. You're going to get a wide array of journals that PubMed is able to sift through. And then they used search terms ADHD and acetaminophen, using additional search terms such as attention deficit hyperactivity disorder, paracetamol, or Tylenol, did not identify any additional results. A total of 96 papers were identified. The initial PubMed search yielded 94 papers, and then they identified 2 additional papers when reviewing the PubMed search. And then those looks like the same 96 were confirmed with Google Scholar. So that's how they got these studies. They excluded papers not related to ADHD and prenatal acetaminophen exposure. So that left them with 70 papers. They also had to exclude animal studies. They had to exclude a few different things. So if we find here, they excluded in vitro studies and animal studies. They excluded meta-analyses. They excluded literature reviews, and they excluded editorials or comment sections, which is, fair. So they started with a bunch of papers. Ultimately they got down to 46 that they included in the review. So that's the amount of papers that they're working with and for what reasons. And so then they took those studies and they used a standardized navigation guide methodology to extract and evaluate data from the identified studies, including, publication year, study design, number of cases, number of controls, total sample size, population type, country, risk estimates, confidence intervals, and the type of neurodivergence that they were looking at. they also looked at if exposure and response relationships were assessed, and all that. So they did their best to kind of standardize things across the board. It, of course, doesn't always work out that way, so you have to approach it kind of with a little bit of skepticism. And they do, like in papers like this, they often do give you insight on their limitations. But a lot of the people that are citing these things are not paying attention to limitations, or like they don't read the study. Like they don't read the study. I can't say either, and or they do not understand the study. So just things to think of. I don't think RFK Jr. and POTUS are actively reading these studies, and I don't think they know what study limitations are. I'd question whether or not they've ever, thought through the scientific method in a way that's coherent. So I don't think they know what to look for in a study. I don't think they know what any of this means. I think they cherry picked their data, and just said this thing agrees with me, and yeah. So, so here, our literature search and application of the study inclusion exclusion criteria yielded a total of 46 studies included in this analysis, with the addition of 4 separate sibling controlled study analyses. This breaks down to 20 studies for the ADHD issue on only 8 studies. So this is important. This is important, folks. Of the sorry, of those 46 studies, only 8 of them talk about use of Tylenol and autism. That is not a lot in the grand scheme of how many they sifted through. That is not a lot at all. And with that, I'm going to take us over to the tables, because the tables are fun. And the tables show us a lot more information than we were given in that press conference. Was it this one? It is this one. And then there was something else that I needed to... Where was it? Oh, I think it was... No, hold on. There was one of these that was color-coded. That's the full-size table. Oh, here it is. Okay. We'll get to this in a second. I just want to make sure that I had it. Okay. So let me blow this up a little bit. Oh, not this page. I need to blow up this page a little bit. Here we go. All right. This is about as good as I can get. So they did review the they have the Alquist study in here from 2024. That's I believe that's the JAMA study. So address inclusion and covariance. Okay, so that's just part of the stats we're not really going to get into. Exposure definition. So they include how they defined exposure, what the outcome was. So for the Alquist study in 2024, it was, have they ever used acetaminophen derived from a midwife interview at 8 to 10 weeks gestation and later during pregnancy? So that was simply, did you use this? Which can be questionable. Again, like, that's if you're looking back at the data during the time. Sure, they probably remember what they took, during that week or whatever. Still left up to bias. But that's kind of a self-reporting thing there. They have this one from 2021. Mothers were interviewed 2 to 4 times during pregnancy using standardized questionnaires regarding postnatal acetaminophen exposure. So again, this is self-reporting. This one from 2016, maternal self-reports, use collected at weeks 12 and 32 of pregnancy. So the other thing too is the self-reports aren't even gathered at the same time in the pregnancy. You have In this one, in 2020 study from Boston, you have measurement of acetaminophen in cord blood samples. So you have fetal cord blood samples, which is more objective data. But a lot of these were self-reported. A lot of them have different criteria. Like, look at this, different outcome definitions entirely. So in the ALCVIS study that we were looking at, their definition of autism was from the ICD-10 codes recorded in the National Patient Registry. So this is like from formal documentation of diagnosed autism. You have, in this 2021 study, you have a subscale of a CBCL scale and DSM-4 criteria. So that's different criteria. You have from the 2016 paper, they have in-person evaluation using the CAST, the Childhood Autism Spectrum Test 13, which quantifies autism spectrum symptoms in children. Each point represents one symptom with a cutoff of greater than or equal to 15 points, having 100% sensitivity and 97% specificity. So, I mean, it's a pretty reasonable test that they're using, but it's not standardized for the other studies. Like, these outcomes could have very different results depending on which test that they're using. The 2021 has from diagnostic records. You have 2019, you have a study saying that the endpoint is being diagnosed with pervasive developmental disorder using unique questions from DAWBA, DAWBA questionnaire. So this is another questionnaire at 91 months, or by mother self-report. So in this 2019 study, you had, in order to be included into the autism group, you could either have this standardized questionnaire at 91 months of age, or just have your mother self-report it, like the mother of the child just self-report, yeah, this kid's autistic. So that's not standardized at all, and it leaves kind of room for a subjective opinion from the mother. You have a 2016 paper saying where their outcome is autism hospital admissions, like specifically psychiatric admissions. So those people are probably going to have a higher need for social support because those people were admitted to a hospital. So that's something that, you have different outcomes. You have different ranges of need for support. You have very different definitions throughout all this of what constitutes autistic enough to be included in this. And so it's just unclear. It's just very unclear what they're comparing against each other because these aren't standardized. And welcome to the chat, Nate and Maya. Welcome. We've been going for a little bit, but feel free to backtrack as you need, or share this pieces of this out wherever. I am going to put all of these citations in the description when we're done here, so you all can go back and find these. But there's a really nice table that I wanted to pull up that really highlights the amount of bias in this particular systematic review. So here we go. So this particular table is a summary of risk of bias in each of the studies. So they have a section for ADHD, they have a section for autism, and a section for other miscellaneous conditions. But we're gonna focus mainly on the autism one because that's the focus of the stream today. But if you see this color, the color coding here, you have the summary of risk bias in autism spectrum disorder studies, with the risk of bias listed here, green being low risk of bias, yellow being some concerns, light red being high, and then critical being dark red. And look at how much critical bias is in the autism spectrum studies. You have critical selection bias, you have critical blinding, critical critical exposure bias. Like the exposure alone, you have such inconsistencies in how much exposure they're tracking or what constitutes exposure, that you have almost entirely bias in this. Like you have a good third of this, even like a half of it being some concerns, and then like another good chunk being critical bias. You have some concerns and outcome bias, very like significant confounding bias that's labeled critical, and again with high and some concerns for confounding bias. You have some pretty decent like low risk of bias in the incomplete data that they address, so they had at least some acknowledgement of limitations. Low financial interest bias, which is great, and then just very critical. So here we have like I didn't see we had percentages here. We have for the exposure bias, we have like almost 40% critical exposure bias in the exposure, and then up to 90% risk of bias within that exposure category in general. And then other bias, you have like for confounding bias, you have up to 50% risk of bias and 50% risk for other bias, which is pretty insane. Like that is, I'm glad that they're admitting this, but if only the press conferences were including this very, very high risk of bias. Yeah, so there's that. There's something else I wanted to, oh, yeah, speaking of financial interest. Okay, so back to AJ previously mentioned the point of leucovorin being used as a treatment for autism caused by Tylenol. And no, this is not. It is not a treatment because autism isn't something you need to necessarily treat. Like you can help people like with social supports as they need them, but you don't need to cure autism. You don't need to cure ADHD. You don't need to cure these things. You just need a society that can better accommodate people. That's really what we need here. But no, nothing is going to cure it. It is largely a genetic condition. You're not going to cure a genetic condition with leucovorin. But it's interesting how leucovorin, like there are financial interests within the administration to sell leucovorin. Specifically, Dr. Oz has some financial interests in this product. So it would make sense that they would want to promote it. So that is something as well. Lastly, I did want to show the 2021 study just briefly. I guess it's not really a study, it's more of a consensus. The paracetamol used during pregnancy, a call for precautionary action. And this one actually looked at not only neurodevelopmental conditions, but also looked at genital malformations. So they're trying to say that Tylenol caused intersex conditions. Also think that it causes early onset puberty and all that. So they say human observational studies suggest prenatal. APAP is also a word for acetaminophen, just an abbreviation for the chemical term for it. Might be associated with both reproductive and neurobehavioral abnormalities in both sexes. APAP exposure during pregnancy might increase risk of male urogenital and reproductive tract abnormalities, as studies have found an elevated risk of undescended testes and reduced distance between the anus and the base of the penis, a measure known as the anogenital distance. Both of these factors are indicators of disturbed masculinization and risk factors for reproductive disorders later in life. So they're trying to say that Tylenol also caused risk of intersex conditions, which I'd be really nervous if people caught wind of this particular study. I definitely don't want them trying to make this connection where we do not see that data. So just be aware that that myth might start coming up, and we might need to come back and talk more in depth about that. But more things that they can use against us. But luckily, I haven't seen much of this going around. This is just something that I dug up in the review of ACOG's consensus. So that's a lot. Oh, and thank you for renewing your membership, Kenzie Page. Thank you so much. I greatly appreciate it. And I greatly appreciate all of you for sticking around. I know that this was a surprise live stream today. I really didn't want to have to talk about this issue, but it, the press conference came out today, and I was like, so much of this is going to be going around. People are going to need sources. People are going to need talking points. They're going to need ways to address this rhetoric. So again, I'm going to put the sources in the description, and including, like, if people came here late in the stream, I do have resources from ACOG, who is really the medical expert body regarding pregnancy care. And there's a great FAQ page addressing a lot of this. So if you can't remember specific responses, or you need a reference to show people, ACOG is a great thing, a great resource to use. So please go back to that. And that being said, there is going to be another medical myth. So you're getting so many medical myths this week. There's going to be another medical myths on Saturday at the usual time, 3 p.m. Eastern time. So this one, I've started my journey, if you will, my journey through fad diets. So this Saturday, we're going to be talking about the very popular influencer sponsor brand Bloom. I'm doing Bloom every day for this week, and we'll be talking about it in depth on Saturday. So I hope to see you all there. Thank you so much again, and we'll see you next time. Bye, everyone.